Well, hello, fellows, I should say, and ladies and gentlemen. Good afternoon. I'm used to saying good evening and good morning, especially when people join from all over the world. But wherever you are, good afternoon. First, I'd like to thank the Academy for the kind invitation. It's really a privilege to talk to you. And I'm extremely grateful and delighted, really, to be elected as a fellow of the Academy. Now, I've had long-time interests in the causes of and substrates of vascular dementia and post-stroke dementia, or at least the sequelae, what happens after stroke, and the interface between what's the common dementia, Alzheimer's disease, and vascular dementia. So I'm going to focus on that. And in the next slide, will it come up? Is really the plan of my talk. I have nothing to declare that, and this is the presentation. After a short background, I will launch into what we call the CogFAST study, which stands for Cognitive Function After Stroke. And I will show examples of some key outcomes and then discuss what it means for each one of us. Now, I think we're all familiar with these posters. Stroke is really an important cause of disability, dementia, and mortality, unfortunately. And you'll see, I've seen these posters even from the British Heart Foundation on the consequences of stroke in terms of vascular dementia. And stroke accounts for almost 5% of disability-adjusted life years, or DALYs, as we call them, and 10% of all deaths worldwide. But the bulk of this burden, in fact, more than 75% are deaths from stroke, and over 80% DALYs occurring in low and middle-income countries. And I'm going to focus on low and middle-income countries in a while. But just looking at the global burden of disease consortium data, I think you can see from this, it's even more common as a cause of death and for among neurological diseases than Alzheimer's disease, what we readily think of in terms of old age. And just to take you a little bit into a historical perspective, so at the outset, I should like to just recount a little bit of history, so we'll put the talk into some sort of perspective. The expression hardening of the arteries, which you may have read about and heard about, as a cause of what we used to call arteriolosclerotic dementia, even until the early 70s. That came in the 1800s. And before that, we had Thomas Willis, of course, with apoplexy. And this pendulum, if you like, has swung in time from all things vascular to Alzheimer's disease, and then I think back to vascular, and I'll explain why that has been the case. Now, many don't believe in vascular dementia as such, that it exists at all. In fact, our North American friends always argue with me. But it is there, and they think that it's contaminated with Alzheimer's disease. However, in these historical developments, I should like to point out two seminal contributions or observations that were made in Newcastle. One was the accumulation of the insoluble material, particularly neurofibrillary tangles or neurofibrillary pathology, was associated with cognitive decline. And the second, the loss of tissue, about 50 mils to 100 mils after a stroke, was also correlated with cognitive impairment or dementia. These two important seminal observations, or rediscoveries, we might even say, were happened in Newcastle with Professor Roth Blessed. And this was something that was quite important. And that's why Newcastle has had a long history of almost 50 years of dementia research. I mentioned VCI in that slide. What is VCI? I'll just come to that, but let's just define what vascular dementia is. Actually, vascular dementia is only the tip of the iceberg, because there are lesser degrees of cognitive impairment, which are much more common. And in fact, 64% of strokes have some degree of cognitive impairment. And then also we find that the conventional definitions that we have of vascular dementia at the moment are not really up to par, as it were, not satisfactory. And so this concept of vascular cognitive impairment came along, and that really means all things vascular, causes of cerebrovascular disease, cardiovascular disease, causing or affecting cognitive function. And we were part of the team that devised this term and that identified and defined it. And of course, VCI then is just a spectrum. So therefore, we needed to think about how we could use this in terms of managing clinically, treatment, and of course, in the clinic. And so, yes, VCI is all well and good, but it also became obvious that it might be cumbersome in terms of the management, as I said. And so this spectrum had to be divided into a sort of mild form, if you like, and a major form. And so two essentially categories were devised, led by our colleagues in Bristol some years ago, and we formed what we call the VIX consortium, as you see in the slide. And under major or severe VCI are these types of dementias that are attributable to vascular disease: post-stroke dementia, subcortical, ischemic vascular dementia, multi-infarct dementia, and mixed dementias where you have also sort of neurodegenerative pathology, Alzheimer's disease, dementia with Lewy bodies, and so on and so forth. And this is what is an important development in this whole process. And of course, major VCI was then also aligned with one significant deficit in terms of severity. And there might be loss of activities of daily living as well when we say somebody has VAD or severe or major VCI. But our interest was what happens to these post-stroke survivors in particular. And just to then remind you of this, just bear with me with this, this little cartoon here. From the bottom, going anti-clockwise, we have where we have strategic infarct, a stroke like in the thalamus, where a person could be functioning very well and then suddenly develops dementia. My mother had a thalamic infarct. She was quite a woman, well-traveled, more than any one of us in the family, and really a grand matriarch, but she suddenly had this hypertensive stroke in the thalamus and then just declined very quickly. Then we have large artery disease, we have small vessel disease, we have leukoariosis, which basically means white matter change, the wiring of the brain is disrupted. And then we have hemorrhages, intracerebral hemorrhage, ICH, and subarachnoid hemorrhages as well. These two hemorrhage types form about 20% of all strokes, whereas the ischemic ones are all on the right there, that are attributed most of the world. Now, just looking at that picture and seeing what stroke is, the most important risk factor for stroke, I think you can see it from this MRI Gini study, is hypertension. Hypertension is a modifiable risk factor, and we can do something about it, as well as, of course, we can do something about diabetes. We can't change our genes yet, although genetics might tell us different. We can't change our age, but we can modify every other risk factor for stroke. And what this study also showed is that the small lesions matter, and individuals with small lesions will live long. So then the question is, what is the impact of these small lesions down the road? And if they're not controlled, what happens to these individuals? Do they remain stable? Do they improve? Do they decline? Do they develop dementia? And what type of dementia do they develop? That was a question. And the mechanisms really then are concerned with this particularly small vessel disease type of. When we think about the small vessel disease category, 20 to 25% of the burden of a stroke is attributed to these. And the patients survive long, as I said, and it's a relatively homogeneous group. And they may also develop depression. Our original idea was to actually follow hypertensives in a prospective study, but that's very difficult because they have comorbidities such as diabetes, metabolic syndrome features, and so on. So then we decided that stroke is an interesting question as well, because what happens to these? So we recruited first-time strokers, if you like, individuals who had stroke, elderly individuals, 90 days after their stroke. And we certified these that are the first stroke by CT scans through stroke registers recruited from 6 different hospitals in the Northeast. And we then followed them from baseline. And this is a plan of the study, which basically shows that at baseline, all stroke survivors were cognitively intact. There were no deficits that we could discern. At least we recruited those individuals. And then so we really wanted to know what is the impact of the stroke that they had over time. And with the Newcastle model, we look at individuals from baseline, assess them annually, and then also, of course, get consent from the families to look at the brains at the end of the day, as it were. And so we can then really compare what we saw in the clinic with what we could find in the brain and correlate. And that was important. And of course, in parallel, we looked at other types of dementias here as well. So what did we find? Well, the glass is half full, if you like. Well, some even improved in cognitive function and in even daily living activities. And 50% a chance of another 5 years. And if they had better outcomes, if their stroke risk factors were controlled. But the glass was half empty, and they had a greater decline if they have more than 2 vascular risk factors. And if their risk factors were not controlled, they declined, they developed white matter lesions, they had lower cerebral blood flows in strategic areas where akin to almost like in Alzheimer's disease, and they had medial temporal lobe atrophy associated with memory function. But the frontal lobe was very important. And you can see from the survival curves that greater the number of risk factors, greater the chance to death or dying early or to develop dementia. And the trajectory showed us as well that individuals remain stable for a period of 12 plus 15 years, but decline steeply in the last 3 years and to develop, especially those who decline, develop vascular dementia. So the clinical implication here is that the clinician should be alert to the possibility of the impending vascular dementia and support strict control for vascular risk factors. And we would say that majority of these stroke survivors developed vascular dementia, and some, about 20% or so, 25% now, had mixed type of pathology, including some Alzheimer's pathology. And small infarcts, things that you can only see with a microscope, were important. Because the large infarcts, they have developed disability, and of course, they're almost sort of excluded from this type of study, and they die early anyway. These are the type of lesions. This cartoon shows the type of lesions that they develop, small lesions, and I won't bore you with all of this in detail. We looked at the frontal lobe carefully and basically showed that there is a vascular basis for degeneration of these large pyramidal cells in strategic areas of the frontal lobe, irrespective of any type of other pathology that was associated with it. So if we control blood flow and perfusion in the frontal lobe, then that is obviously a very good thing. And similarly, the wiring of the brain, the white matter, as you see in the decliners, there's a lot more of that white matter blobs that you see in the lower scan compared to the stable people. And again, the pathology investigation right from the clinic neuroimaging to pathology at postmortem showed that in the white matter, they developed abnormal astrocytes that had end feed to the capillaries were retracted. And so the water channel and the communication between the blood and brain was disrupted. So the blood-brain barrier in the white matter is severely damaged, as it were, in these decliners. And taking those further with transcoptic profiling studies, we showed that there are indeed problems with in terms of dysregulation of metabolic signaling and cellular molecular machinery. And then just turning to Africa in the last 2 or 3 minutes, I just want to say that in Nigeria, we found exactly the same data or results, where we had an arm in Nigeria to basically, the idea was to follow these individuals, younger age, but different diet, different lifestyle. And they also wound up with medial temporal atrophy, high frequency of VCI among them. And you might wonder, how do we test cognitive function in these individuals who have never put pen to paper? Well, this is one of the spatial orientation tests where the subject is expected to put those matchsticks in that as a fork. And you can see the examples they came up with, especially those who declined. And these are scored, and that's how we measure cognitive function, for example, in one way. The Nigerian study also showed something very important. Education, less than 6 years of education was a risk, a very strong risk. But if we ate fish daily prior to stroke, it was protective by more than 40%. And this was, so eating fish is good, ladies and gentlemen, every day, not just fish and chips once a week or every other day. And then in the animal studies, I just want to take this further to show that in the animal studies also showed that enriching the environment was important. When we occluded the carotid arteries, reduced the blood flow to the brain, but then put these mice into cages with an environmental enriched cages, then we could reduce 50% of the strokes that came after that occlusion of the carotid arteries and in the lower perfusion. So remarkable. Again, lifestyle change, modifiable, and it can be done. So this is just the summary of what I wanted to say this afternoon, where we might have vascular disease, a risk that we can really control. And hypertension comes to mind foremost, as I've illustrated in the data from the MRI Gini study, for example. And our data showed the same. We can do something about it. That causes a vessel change. And if that causes a vessel change, then it creates a hyperperfusive state of the brain, which leads to disruption of the wiring of the brain, the white matter. And depending on the original impact, the degree and the duration of the original insult, it may lead to these pathologies, including Alzheimer's disease. So when we don't have a cure, or definitely, or really a better way for all types of dementia, you know, we've tried amyloid beta reducing drugs, vaccines, and the pharmaceutical companies have spent a lot of money. But just changing lifestyle and improving our vascular health is important, as shown by the MRC CogFAST study, which Newcastle is part of, as you see here. And then now, just to show you that, you know, this is not rocket science here or cosmic science, but let's control our blood pressure. And we have individuals walking and talking with blood pressure like that.